Good morning, friends. Am I audible and visible to you? Yes or no? Please, one of you can chat board. Yes? Roll number 33. Am I audible and visible? You are unmuted. Please say yes or no on the chat board. Yes, sir. Okay. Good morning, all of you. Today, I would like to talk to you on Wilson's disease. Wilson's disease is an inborn error of metabolism connected with the copper metabolism. It's not a very common disease. It is a rare disease, but not at all uncommon in India and the Far East. Why it is important is, from your theory aspect, Wilson's disease is an interesting, it forms an interesting questionnaire for the examiners. One is the disease per se, the short notes pertaining to the wing beating tremor, and the drug therapy of Wilson's is fascinating, like the depenicillamine, the triantine, the zinc. All these things, they form an interesting aspect. So anything can be put as an essay question or a short note question. That's why I selected this topic, Wilson's disease. It has got a plethora of symptoms, and some of the signs are interesting from a clinical point of view. Basically, on the screen, you are sharing an image of Kinnear Wilson, who first described this Wilson's disease. Wilson's disease, as I already told you, is an autosomal recessive disorder connected with ATP7B gene, which is at fault. This is responsible for the binding of ceruloplasmin and copper to apoceruloplasmin, thereby leading to ceruloplasmin, which is a copper binding protein circulating in the blood. In the presence of a mutant gene, ATP7B, residing on chromosome 13, what is happening is all this mechanism goes haywire, thereby leading to disturbance of the copper absorption, copper excretion, and copper deposition in abnormal organs. The excess deposition of copper is commonly seen, and most of the deleterious effects of this excess copper deposition are seen commonly starting with the liver, then the CNS. Rarely, it can be deposited in the bones and other tissues. But the most important things are, immediate importance are the liver and the CNS. Other structures that can be organs that can be affected are the kidney and the bones. So, this Wilson's disease is, as I already told you, it's an autosomal disorder. The frequency is 1 in 30,000 or 1 in 40,000. Commonly seen in the Scandinavian countries and the southern part of Europe, like Sardinia, southern part of Italy. And these are the countries where it is commonly seen. Even in the US also, these diseases are seen. The manifestations of Wilson's are also seen in the US also. In India and in the subcontinent, Indian subcontinent, Wilson's disease is occasionally seen. Why it is important is the type of presentation that is seen in the Indian subcontinent is the people that are seen at an younger age group. Say, usually Wilson's manifests from the age 5 to 40 or 5 to 60 years also. Sometimes it can be extended by one more decade. But in India, it makes its presence much earlier. So please remember, in children with abnormal behavior, abnormal neurological problems, presenting with unexplained hepatitis and a tremor, involuntary movements, one has to exclude Wilson's disease if there is already a history of consanguineous marriage and an index case in the family, because it's an autosomal recessive one. So that's more important. You should have a high index of suspicion and screen these people born out of wedlock and consanguineous marriages and near relatives of first degree cousins. Think of Wilson's. as an alternative, not as a dustbin diagnosis. It's not a diagnosis of exclusion, but it should be suspected. Wilson's disease. What are the important features of Wilson's disease? The pathology is, as I already told you, ATP7B gene goes mutant. The mutations can be up to 300 or even more. So, when once this abnormal mutant gene is present, it prevents or blocks the binding of copper in the liver, and thereby the free copper is released into the blood, and the secretion of copper into the bile is blocked, and this is secreted. The what many people says, a free copper is secreted into the blood after causing sufficient damage to the hepatocytes. That's why a latent period of 3 to 5 years may be passed, because before there is a damage of liver hepatocytes, it can be stored, but finally there is partial damage to the liver structures, the hepatocytes, they will be releasing the excess load of copper into the blood. This is known as a free copper. And this copper, mind you, will be released into the tissues, various tissues. The liver is already deposited having so much of copper, excess copper. And in the brain, the deposition of copper can be seen in the basal ganglia commonly, the cortex, the thalamus, the subcortical structures, even cerebellum also can be seen with varying degrees of damaging, thereby producing neurologic and neuropsychiatric manifestations. So, the importance of excess deposition of copper into this brain is manifest at a later time when compared to a hepatic manifestation. Similarly, the kidney can be affected, thereby producing proteinuria, microscopic hematuria, and symptoms similar to renal tubular acidosis, and not a full-blown Fanconi syndrome, but a microscopic hematuria, renal tubular acidosis, and near Fanconi syndrome. These are some of the manifestations of this. And similarly, the joints will be involved, thereby producing arthritis. Usually, the knee joints are more common affected. These are some of the affectations. Then coming to two important clinical features of Wilson's. You must have been fascinated throughout your career. You must have heard of two things. One is deposition of copper into the ophthalmic findings. There are two ophthalmic findings. One is the KF ring, Kaiser-Fleischer ring, and the other one is sunflower cataract. Some people are fascinated about, they may ask you what's a KF ring and what is a sunflower cataract. KF ring, mind you, is seen at the limbus of the sclerocorneal junction. It's a deposition of excess copper into the Descemet's membrane of the cornea, and mind you, it starts at the upper margin of the limbus and gradually progressing to complete a circle. So, presence of a KF ring is, though it's not the sine qua non of Wilson's disease, it is seen in 99% of the patients of neurologic Wilson's. In neurologic Wilson's, the association between a KF ring and Wilson's disease is very well established. It is seen as commonly as 99%, whereas in hepatic Wilson's, it's of the order of 50 or even less, and even in
Hello.
symptomatic cases, it can be
Mm.
around
Let me ask you.
40%. Coming to clinical presentation, average age of presentation with liver transplant.
Mhm.
The
Mm. No. Mm.
average area of presentation is,
ఏంటి
the hepatic manifestations will be coming early. So between 5 years and 50 years, the manifestations will be usually earlier. The hepatic manifestations are being seen like recurrent jaundice, a recurrent hepatitis without jaundice, progressing to pulmonary heart failure if it is fully manifest. And this makes one suspect whether the patient is having any iota. This raises an iota of suspicion whether the child is having features of Wilson's. More so if there is a family history and a history of consanguineous marriage is there. This is followed several decades after by neurologic Wilson's. Neurologic Wilson's is more disabling, ultimately leading to a totally disabled person because it can have a variety of manifestations in some irregular tremors, a back ringing tremor, chorea, athetosis, dystonias, dysphasia, dysarthria, and even dementia can also be seen. Paranoid psychosis, paranoid disease states can also be seen. So psychotic features can be seen. So there are a variety of symptoms that are associated with a neurologic Wilson's. That's why one should pick up the diagnosis early to prevent the more disabling neurologic Wilson's. Neurologic Wilson's is more disabling to the patient in that he'll be having the three Ds. One is the dysphasia, dystonia, and dysarthria, and dementia, tremor, ataxia, psychiatric manifestations, and the classic wing beating tremor. Wing beating tremor, and there is a short video on Wilson's that will be coming at the end of my talk. Coming to diagnosis. The diagnosis of Wilson's is very simple. Previously, people used to attach a lot of significance to serum ceruloplasmin level, serum free copper levels, and the deep enzyme test, histologic features, and hepatic copper estimations and mutation analysis. Of all these things, nowadays the priority has been changed. Low serum ceruloplasmin levels, say less than 20 milligrams per deciliter. Previously, people used to attach a lot of significance. Nowadays, it's not so because it is not totally foolproof and it is totally reliable. So next is serum free copper level. This is also people are now not relying very much on it. The most important things are elevated 24-hour urinary copper levels. Elevated 24-hour urinary copper levels. When it is more than 100 micrograms per day, yes, you can suspect or it is one of the positive findings. So in an order of 4, scale of 4, it gives 3 plus to the score. So normal being 20 to 50 micrograms per day, the level of 24 hours urinary copper levels is more than 100 micrograms. Please remember one thing, it is not totally free from the fallacies. The way it should be collected and the way it's collected is more important. And similarly, elevated urinary copper levels after giving a standard dose of 500 milligrams of D-penicillamine at the beginning of the treatment and measuring it, if the levels are more than 1600 micrograms of copper in 24 hours, yes, it can clinch the diagnosis, but it is a therapeutic challenge. Giving 500 milligrams of depenicillamine, collecting the urine for 24 hours, estimating it. After that, if the values are more than 1600 micrograms, yes, one has to safely conclude that this can be a case of Wilson's. But the gold standard is liver biopsy and doing the liver biopsy and weighing the copper in the dry liver. This is supposed to be the gold standard test. Normal copper in a dry desiccated liver is 20 to 50 micrograms per gram of liver, whereas it will be elevated up to the level of say more than 250 micrograms per gram of desiccated liver is highly diagnostic. So, a six-fold increase in the level of copper of 1 gram in a desiccated liver is highly suggestive. At the time of doing this biopsy, liver biopsy, one can subject the slide for histopathology. But please remember the HP findings are not at all specific. They are non-specific. They include and they depend rather on the presentation and the stage of the disease at which it was seen. The features include a massive necrosis, steatosis, glycosylated nuclei, chronic hepatosis and hepatitis, fibrosis and cirrhosis. Yes, these are some of the changes that are seen in association with Wilson's disease in the liver. And the last test that can be tried in 50% or more than 60% specificity sensitivity is if all the measures like this urinary level of copper and the dry copper in a desiccated liver biopsy specimen, if still somebody is in doubt, one can do a mutation analysis by whole gene sequencing, and that can be performed on individuals in whom a diagnosis difficult to establish clinically and by biochemical testing. So this is the ultimate thing. Coming to this is something about autosomal recessive inheritance. Something about treatment. Previously, people used to do a lot of emphasis on certain chelating agents. The purpose of treating a patient with Wilson's is number one, to minimize the neurological handicaps, to arrest the progress of the disease, because if it can be diagnosed early, Wilson's disease, mind you, is totally treatable and curable without much sequelae. If at all there is any damage to the liver structure, that will be remaining as a residual handicap, but liver has got enormous regeneration and reserve capacities. So Wilson's disease by far is totally curable provided at what stage you are starting the treatment. Before going in, the individual is going for a fulminant hepatitis, or before the individual is going for paranoid schizophrenia and irreversible changes in the brain. So the aim is, first thing is drive out the excess copper in the body or minimize or reduce the dietary intake. Certain cereals, liver and some vegetables, they are very rich in copper. So our aim is to, in a preventive aspect, try to minimize the intake of dietary copper. Number one. Number two, once there is an excess copper in the body, your aim is first to drive out the copper to the extent possible, making the patient to normal levels and maintaining it at. By the word maintaining, I mean to say the process of treating Wilson's is almost lifelong. It is almost lifelong, stabilizing the patient. So there is nothing like a cure and go. It's not like a touch and go. It is almost regular and doing regular monitoring of the copper levels, ceruloplasmin, and associated hepatic parameters and other metabolic parameters, renal, the hepatic parameters, monitoring them regularly because this is a long drawn process. Roll number 33. 33. Am I audible, sir? Roll number 33. Please unmute yourself. 33. Hello? What are the drugs that are used in the treatment of Wilson's disease? 33. Uh, Please note the number, Surya. Is not there? Yes. There are? Absent? Yes, please. 33. If you are not responding, I'll be forced to give your numbers. The people who are remaining mute, I have to give the numbers to the Dean sir and HOD sir. Please answer, at least on the chart board. What are the drugs that are used in the treatment of Wilson's disease? Roll number 33. Leader. Please note the number. Plus 33 రాసుకో చెప్తాను. 33 once again. Now roll number 53. 53.
Yes, sir.
Yes. What's your name, madam?
Abhigna, sir.
Abhigna ji. Good morning. What are the drugs that are used in the treatment of Wilson's disease?
Zinc, triantine, zinc, penicillamine.
Okay. Penicillamine, you said? Penicillamine?
Sir?
Penicillamine is there?
Yes, sir.
What is the next thing?
Zinc,
Yes, what else?
triantine.
Yes. You should have put them in an order. Penicillamine, instead of plain penicillamine, a better word is a D-penicillamine. What does the D stand for? Amma?
Don't know, sir.
You don't know? That's also it starts with D. Don't know? D stands for a dextroform. Okay?
Yes, sir.
A dextro, what is that? A dextro, what's that drug? I have forgotten.
Penicillamine.
Dextropenicillamine is one thing. Okay? The next thing is not zinc. The next thing in the order is triantine. These two are basically chelating agents. Okay?
Yes, sir.
They form complexes with the metals, heavy metals, not only in copper excess, they can be used in a variety of conditions where there is an excess load of heavy metals and sometimes poisoning also. Okay?
Yes, sir.
Roll number 63.
Yes, sir.
Yes, good morning.
Good
What
morning,
form of, what form of zinc you want to use? Zinc?
Zinc estates,
Excellent. What's the dose like?
sir.
What is the dose of zinc acetate?
Those I don't know, sir.
Any other drug that can be tried, an experimental drug, apart from the D-penicillamine, triantine, zinc, anything? Anything connected with the molybdate?
Ammonium
Very good.
tetrathiamolate.
That's an experimental drug, not routinely available all over the world. It's a bit costly. But coming back to the D-penicillamine, thank you. Coming back to D-penicillamine, Abhigna, you said something about penicillamine, is it not? It is D-penicillamine.
Yes, sir.
Why don't you use L-penicillamine in its place? L stands for levo.
Liver.
Yeah, can you use it? If D is not available, can we try the L form? Yes or no?
No, sir.
You can try or you can't try or you don't know.
I don't know, sir.
You don't know. Okay. The thing is, D-penicillamine cannot be inter-exchanged or cannot be exchanged with levo form. The levo form and the racemate form of it are very, very, very toxic and they produce worsening of the neurological symptoms. That's why D-penicillamine is the drug, if at all, that has to be used. This is given in your tripartite. Please, today we refer to a tripartite. There, this point is given. The racemate form and the L form of penicillamine cannot be given for fear of worsening the symptoms of neurologic Wilson's. Now, coming to D-penicillamine, previously D-penicillamine was a drug of choice. D-penicillamine, triantine are the drugs of choice because they are the only drugs that are available. But of late, they are not finding favor, especially the D-penicillamine, because it is supposed to be very toxic and produces so many complications. It is associated with many complications like renal damage. And mind you, it can't be given in neurologic Wilson's. The triantine and D-penicillamine cannot be given as the first drug of choice in neurologic Wilson's because they will be causing worsening of symptoms. That's why never D-penicillamine in neurologic Wilson's. And never alone, plain D-penicillamine is given. D-penicillamine, the dose is 500 milligrams QID or BID, divided doses. It can be given up to a dose of 2000 milligrams. This was a previous story. Now people are discarding this D-penicillamine. Whenever you are giving the D-penicillamine to the patient, the precaution you should take is roll number 73. What's the precaution one has to take whenever D-penicillamine is administered? 73. 83. Unmute చేస్తామని 83. 83, please.
Yes, sir.
Yes. What's your name, ma'am?
Maunika, sir.
Monica, see, please. What is the co-prescription you should give whenever you are giving a prescription of D-penicillamine? Mind you, D-penicillamine is a long-term process. So, what is the drug you have to prescribe as a co-prescription with penicillamine? Please. Monica ji.
Yes, sir.
Yes, please. You read about Wilson's disease or not? Amma? Yes or no? Amma, you read about Wilson's disease? Hello? Monica ji, say yes or no? '83. What about 93? 93.
Sir,
Yes, 93. What's your name, sir?
Sandeep, sir.
Sandeep.
Yes, sir.
Sandeep, whenever you are prescribing D-penicillamine for a particular patient with Wilson's disease, what is the important co-prescription one has to give? Please. Any B complex vitamin? You can use your chat board.
B6, sir.
What vitamin B complex you want to guess? It's B6. I think 83 answered it. Okay, right. Vitamin B6 is right. It is B6, pyridoxine, because pyridoxine has to be a co-prescription whenever you are giving D-penicillamine anyway. And mind you, D-penicillamine is not routinely prescribed. I'll show the next slide. And D-penicillamine is not a routine prescription now. And the drug that is nowadays finding favor of late is Trintine. Trintine, the dose is more or less similar. But the advantage of Trintine over D-penicillamine is it scores over D-penicillamine in a way it is relatively safe in pregnancy, less toxic as far as the neurological Wilson is concerned. Mind you, you cannot give straight away this D-penicillamine business to neurological Wilson's because for the fear of worsening the symptoms. So patient will not be cooperative. Plus, mind you, his symptoms will be worsening. So the drug that can be given, if at all it has to be given, is a Trintine, another chelating agent. The dose is more or less similar. And the advantage of Trintine is it can be given in pregnancy as well. Whereas D-penicillamine can't be given, whereas Trintine can be given in pregnancy also. And this tetramolybdate is one drug that is experimentally tried in neurological Wilson's. I'll come back again, coming to the highlighting the advantage of zinc over other drugs. Zinc. If you can see this slide, it explains all, it shows all. This is from Harrison, not yet completely adopted in our country. where depenicillin is still prescribed, but this is the standard protocol. Initial hepatitis and cirrhosis without decompensation. The best drug is zinc. Zinc acetate in a dose of 50 milligrams 8 hourly. Orally, it can be given and it is cheap, effective, less toxic, or free from side effects. The only side effect that is described with zinc is gastritis and nausea. Other than that, it can be given. But please remember, zinc interferes the absorption of other important molecules and metals in the diet. That's why whenever you are prescribing zinc, there are two precautions. One is whether you give it with triantine or whether you give it with depenicillamine or zinc alone, it must be given 1 hour apart, not too tandem, too close. 1 hour gap must be maintained for minimizing the interference of zinc or the absorption of other metals in the dietary food. Okay. So zinc can be given 1 hour before food or 2 hours after food, but water is no problem at all. You can drink plain water that's given there on the fourth line. Food and beverages other than water. Okay. Triantine depenicillin also should not be given too close. A gap of 1 hour before or 2 hours after must be maintained. If you don't maintain this, what will happen when you are giving this to a pregnant lady is zinc goes on getting out of the body through gut. Zinc along with the copper. So there is a relative deficiency of copper in a pregnant lady. This can cause teratogenicity in the baby in the first trimester. That's why you must maintain a carefully guarded level, not too tight control in a case of pregnant lady. Please remember that. In a pregnant lady, it shouldn't be too tight. You have to allow some extra allowance for the development of the baby in utero. Otherwise, the baby may be born with some teratogenic effects. Okay. This is something about zinc. Zinc is safe, effective, and relatively free from side effects. It can be combined with any drug, but for the dietary restrictions. If you can see at this slide, yes, first choice is zinc in hepatic. In hepatic decompensation, mild, once again, triantine and zinc. Moderate, it is triantine and zinc again. Then severe, for severe hepatic decompensation, as you are going by a NASR scoring system, more than 7, between 7 and 9, NASR score is not necessary for you. There you have to go for a hepatic transplantation. This is the ultimate thing. So, depenicillamine, zinc, and others are, they form the second choice. If you can see the right side of the table. Then initial neurologic psychiatric symptoms. Initial neurologic, always remember, neurologic Wilson's should now be prescribed for initially the depenicillamine batch. Depenicillamine and triantine, they will be aggravating the symptoms. So never, the drugs that can be tried are a tetrathiomolybdate. Otherwise, the ముద్దు ఏంటంటే thiomolybdate, not available in India. Then zinc. Then coming down, the psychiatric, the pre-symptomatic, the pediatric, the zinc, all these things. Zinc is the mainstay of treatment, very cheap, effective. Coming to the alternative is, the second drug is a triantine, known as cyprine. Depenicillamine is known as cuprimine. Triantine is known as cyprine. These are the drugs. Okay. Other things are relatively to alleviate the symptoms, we give them. Just to minimize the symptoms, if there is a tremor, treat the tremor. If there is a paranoid schizophrenia, treat the paranoid schizophrenia. If there is an asymptomatic jaundice or hepatocellular failure, go for it. The role of surgery in these people is, it can be tried in a case of pulmonary hepatitis. Once a pulmonary hepatitis is treated with surgery, most of the hepatic symptoms may subside. But coming to neurological symptoms, once again, the mainstay of treatment is zinc. And mind you, the most important message of the day is, the treatment of Wilson's disease is lifelong. It needs regular monitoring as far as the blood count, the liver panels, the kidney panels, and the symptomatic relief, whether it is in excess dose or underdose. A word about females and Wilson's disease. In the female, a certain subset of patients will be presenting with amenorrhea, irregular periods, and sometimes one has to suspect if there are repeated abortions as far as her gravidas status is concerned. If a female is aborting regularly and habitually, if there are other because diagnosis can't be clinched, think of Wilson's also as a co-diagnosis because Wilson's disease can be manifest as a with the symptoms of repeated abortions, amenorrhea, and irregular periods in the females. So that is the importance of it. Coming to KF ring. This KF ring, is it a permanent addition or is it a transient feature? Roll number 93 once again. Sir, will you please answer this? Roll number 93.
Sir,
Yes, you were told about KF ring. Okay?
okay, sir.
This KF ring is due to
Copper deposition, sir.
abnormal deposition of copper in the
Cornea, Descemet's layer of cornea, sir.
excellent. Is it a permanent feature or is it a temporary feature? Can it be reversed or not?
Reversible, sir.
Yes, very good. With treatment, with the initiation of treatment, this can be reversed. Okay. In children, do you
Yes.
find this? How often do you find this carefree?
Don't know, sir.
Common or less common or not at all? In children, tapering is a must.
Common, sir.
It's not so common. Okay.
Okay, sir.
In children, it need not be common. Roll number 63. Hello.
Yes, sir. Yes, sir.
Yes. This K-frame, is it sign qua non of or pathognomonic of Wilson's or can it be present in other conditions like? Can it be
Yes.
present in any other conditions apart from Wilson's?
Chronic liver diseases.
Very good.
So 1 second.
You want to consult the Google? Yes?
No, sir. No.
No, what? Okay. Amma, what are the other conditions? Chronic liver disease is one. Biliary atresia. Then is
Oh.
chronic congestive hepatitis. These are some of the conditions where biliary stasis, wherever there is a biliary stasis, it can be seen as an accompaniment. But with neurologic Wilson's, how often it is seen? Which percentage? Is it 20, 40, 80, 90, 9?
Don't know, sir.
Okay, roll number 33.
Sir,
How frequently it is seen in neurologic Wilson? How frequently it is seen in hepatic Wilson? Which is more common in which type? KF is more often seen in hepatic or neurologic?
neurologic.
Very good. Okay. How frequently it is seen?
I don't know, sir.
Norma. It is 99%. Okay.
Okay.
When you see a patient with KF ring, think of Wilson. Okay.
Okay, sir.
And not the vice versa. And in hept- hepatocellular degeneration, what is the frequency? It's 50%. It is less. The association is less. So it's not a diagnostic foolproof method in case of for the diagnosis of insulin. And roll number 36 is there. What's her name? Bhavishya or Vaishnavi? 36. Vaishnavi is there. Vaishnavi? Hello? Hello? 36. Name is not necessary, compulsory. 36 I want. Well, no, 36. 36 is absent. 36. I presume 36 is absent. Or if there is any hesitancy, please use the, if there is any hesitation, please use the chart board. Yes, 36. 36, please. All of you have gone past your after examination. It's not. How do you diagnose a case of this KF ring? Any instrument is there? 33. Roll number 33.
Sir,
Yes. What is the ophthalmic for the diagnosis of KF ring? Opthal.
don't know, sir.
You don't know. Okay. Somebody has a slit lung. Please. Okay, good. Something about Wilson. Okay. Now this will be followed by 2 short videos. I hope you will definitely, it will be useful to you. The classical tremor that is seen in Wilson's disease is known as bat winging tremor or wing beating tremor. Slides slides diabetes video Yes. In 2 days from today, we will be celebrating November 14th. It is a threefold celebration. One is Children's Day. The other one is Deepavali. The other one is, yes, somebody in your class celebrated last year. Last year it was a memorable day. The morning walk, the bus ride, Nal Tapakailu, the freebies, and the lecture and the exhibition. They were all awesome and memorable. I think most of you enjoyed it. So November 14th is designated as World Diabetic Day just to celebrate, or the day is coinciding with something else. Yes, you can see this iconic photo. Okay, roll number 49 is there. 49.
Yes, sir.
Yes, ma'am. What's this? What's this slide? Does it have any connection with the World Diabetic Day? Yes or no? Yes, madam. Does it got any significance? November 14th every year? Internationally? You know or you don't know?
I don't know, sir.
Last year you celebrated. I think
Yes, sir.
you distributed chocolates in the class also.
Yes, sir.
Okay, okay. Very good. I think Samyukta will be answering it, but let us not disturb her. The photo is an iconic photo. This is completing nearly 100 years. This is the start of an epic era whereby rewriting the history of diabetes. The people in this photo are, one is, the young one is Best, he is Banting, and this is Marjorie. Banting, Best, and Marjorie. The birthday of Sir Frederick Banting falls on November 14th. He is the man who is responsible for the discovery of insulin. The experiments were done on Marjorie. So, this child, I forgotten his name, morning also read, he was the first patient or first recipient of crude insulin extract. This comes in another 2 days. That's the World Diabetic Day. That happens to be the birthday of Banting is celebrated as World Diabetic Day. This is important, and you should remember these people. At least you should remember the discovery of insulin is now going into the, or it is, the centenary celebrations will be on next year. Yeah. I thank you all. Wish you a very happy Deepavali, safe, happy, and healthy Deepavali. And next year, probably, we will be celebrating in a better times, better mood, all of you as house agents. I wish you a long, happy life. Thanks for your patient listening. Okay? Vaishnavi is absent today, or is she hiding somewhere? I'll verify it. Okay? Answer. Thanks for a patient listening. Good luck to you. Now you see the videos. They are very, very useful for you. Okay. Please stay for another 10 minutes. 2 videos are there.
To get through the diet is copper. And typically we take in about 1 to 2 milligrams per day from the food we eat. Things like whole grains, beans, nuts, and potatoes. But really our body only needs about 0.75 milligrams per day. So that extra copper is excreted. About 90% of the excess copper is excreted into the bile, where it eventually ends up as fecal copper. And the other 10% is excreted in the urine. In Wilson's disease, there's this genetic defect that results in the excess copper being kept in the body and deposited in various tissues, where it's definitely not supposed to be. And just like iron, free copper can react with hydrogen peroxide in the body to form the hydroxyl radical, a reactive oxygen species that's pretty good at damaging tissue. So over time, those tissues are seriously damaged by free radical generation. Now, your liver cells, or your hepatocytes, play a really important role in helping the body get rid of excess copper. So usually the copper from the diet is absorbed into the stomach and small intestine via enterocytes and passed off into the portal vein to the liver. Once it's in the liver, it's sent to a special transport protein called ATP7B, which has a couple super important jobs. The first job is that it binds copper to apoceruloplasmin, which is the major copper-carrying protein in the blood and is responsible for carrying about 95% of the copper in the blood. After it binds copper, it's then just called ceruloplasmin, and this guy can haul 6 molecules of copper at once. ATP7B's other job is to gather up the rest of the copper into vesicles to be exocytosed into the bile caniculi, where it goes into the bile and is eventually excreted. With Wilson's disease, there's this autosomal recessive defect in the ATP7B transport protein. As you could probably guess, that means that it can't incorporate the copper into ceruloplasmin or excrete it into the bile. Since it's not doing either of these things anymore, the copper builds up inside the hepatocyte and starts to produce free radicals. Eventually, all this built-up copper and free radical damage injures or destroys the hepatocyte, causing free copper to spill out into the interstitial space, and from there it can access the blood supply. Once it's in the blood supply, it's circulated to and deposited in other tissues, where it also causes free radical damage over time. One organ in particular is the brain, And for this reason, Wilson's disease can have serious neurological symptoms and complications. Depending on where it deposits, it can cause different disorders. If it deposits in the basal ganglia, it can cause a movement disorder that's a lot like Parkinsonism. If it gets to the cerebral cortex, it can be toxic to neurons, which can lead to neuronal cell death and dementia. One place that it can also deposit that can be sort of helpful for diagnosis is in the Descemet's membrane of the cornea, which is this membrane between the stroma and the endothelial layer of the cornea. So you'll look for something called Kaiser-Fleischer rings, which are visible copper deposits in this membrane of the cornea. Since it starts in the liver, though, liver damage is usually seen first, right? And it often progresses from acute hepatitis to cirrhosis and liver failure, and symptoms usually present in late childhood. Typically, when you look at someone's blood with Wilson's disease, you'll note a couple pretty key things. One is that there'll be an overall decreased level of ceruloplasmin in the blood. Because remember that you need apoceruloplasmin to bind to copper for it to be called ceruloplasmin. So without ATP7B binding copper to apoceruloplasmin, all you have is this apoceruloplasmin, which is relatively unstable and doesn't last very long in the plasma. And this can be important for diagnosing Wilson's disease early on. Another key feature to note, though, as hepatocytes are damaged and release free or unbound copper, there'll be increased levels of free copper in the blood, right? Which will also lead to increased free copper in the urine. Other common complications from deposited copper in other tissues include an enlarged liver and spleen, hepatosplenomegaly, renal disease due to damage to the proximal tubules of the kidney, and hemolytic anemia due to the direct damage that circulating free copper causes to red blood cells. As far as treatments go, penicillamine will usually be used for Wilson's disease. Penicillamine is this alpha amino acid metabolite of penicillin, but it doesn't share the same antibiotic properties as penicillin. Instead, though, it's a copper chelating agent, meaning it binds to free copper in the serum and makes it easier to excrete. Also, though, patients can be given zinc or ammonium tetrathiomolybdate, both which reduce copper reabsorption in the urine and therefore increase the amount of copper that's ultimately excreted in the urine. Finally, if the liver's been damaged to the point of cirrhosis and liver failure, a liver transplant might be needed.
Dear friends, next video is being played. Please, this is a classical wing beating tremor of Wilson's disease. This is a classical video. Thank you. Thanks for a patient listening, and I hope you enjoyed the video. Signing off. Thank you. This is my mail ID. If anybody gets any doubt, you can use it. Okay. y.sashkira1@gmail.com. Anytime you can feel free. This is my email ID. Good luck. Online.